Welcome to the Absite Smackdown podcast. We'll talk clinical scenarios, interesting Absite facts, and interesting general surgery knowledge. Now, let's get to it.
Hi, welcome back to Absite Smackdown podcast. I'm your host, Jessica, and with us today, as always, is Dr. David Kashmir. And then we also have joining us Dr. Rhonda Barsom. Hi, guys.
Hey, Jessica.
Hi.
Good to be with you guys both today. I'm really looking forward to it. This is really going to be a great episode.
Tell us why.
Well, today we're going to talk all about recent experiences with the Absite. And we have, like you said, Dr. Rhonda Barsom, who's from the ProjectSmackdown team. And it's just been great to work with her as we develop the new edition moving forward for the Absite Smackdown review. Dr. Barsom is originally, most recently from New Jersey, and she came through Jefferson Medical College in Philadelphia, and then now has gone on to be a successful PGY3 resident in the GME Consortium Residency out of Las Vegas. So just like you said, Jessica, welcome, Dr. Rhonda, to the program.
Thank you.
So today, we're going to go through just some of the recent experiences. And I know, Jessica, you were talking to me offline before about just how different things are in the age of COVID. I know, and we're so lucky today to have Dr. Rhonda with us. Where do we go?
Well, Dr. Rhonda, thank you again for coming on. I'm so excited to have you on the team and be here with us. And what we have been talking a lot about is just how the impact of this year versus your other residency years, how it's different. And we just want to get, because you're a resident year 3, what you've noticed, what you've experienced, and the changes that have happened to you.
Yeah, so I think that the patient care has been maintained very well. I am very proud of how our residency program and how the hospital has done a great job, taking care of every patient regardless of diagnosis, regardless of positive or negative status of COVID. We did absolutely see a very different patient population, different diseases that we don't know what we're dealing with, as a country and as a world right now. But the impact on our education has been minimized, to say the least. Really, in our program, we've maintained our rotations. We maintained our case numbers. We maintained all of our experiences, even our didactics. So while it definitely threw us for a loop, this time last year, we've definitely been made stronger and have learned more and have definitely built up a database for research for decades to come.
So you feel like everything adapted pretty quickly, that you guys were already at a place where you were able to adapt to the changes and still give that level of care, still get your education. What do you think prepared you for that? What do you think they had in place that made this easier for you guys to acclimate to the situation?
Truthfully, I think our program director, I think Dr. Joseph did a great job acclimating us and, having this forethought and planning that he needed. So in the beginning of the pandemic, he actually split us up into teams where every team would take 14 days off and the other team would work the 14 days. And that way, that if any one of us was exposed or had even a risk of being exposed, we knew we weren't in the hospital and we knew we had the 14 days to recover after. So just having that leadership, I think, from Dr. Joseph and our chair, Dr. Ellis, who just sat down and just formulated a plan that was both, Dr. Joseph always says a good surgeon has plans A through F already in their mind before they walk into the OR. And I feel like for a lot of things in life, he and Dr. Ellis always have plans A through Z. And I think that's what helped us out a lot, help us to acclimate, help us to get our case numbers, help us to stay away from places that would, potentially put us at risk. So I'm giving him a lot of credit here, really.
The Absite Smackdown podcast. Visit the Smackdown at absitesmackdown.com.
It's wonderful. That sounds familiar, doesn't it, Dr. David?
Yeah, we must all read from the same book. And it sounds like their background is similar to mine and same kind of attitude. I think that really brings you really pretty far, like Dr. Rhonda said. And that was able to get them through a tough time too. So it's good to hear. What a great plan, and sounds like a great leadership team there. It's really great.
It sounds like it touched also not just on your physical health, but your mental health. That was something that we had talked about one of the recent podcasts with Dr. Carlos on how important it is for your residents to not just have your physical health and be in there in your education, but your mental health too, and how that contributes. And so it sounds like your program director really had that in mind with you guys, and it's awesome.
Yeah, we have a lot of wellness activities, and obviously the wellness activities were kind of stunted because of COVID, but we got creative. We had Zoom meetings, we had game nights, we had very small, potlucks, but nothing too big, nothing that required us to go out, nothing that required to put us in any type of danger. So we maintained our wellness quite well, even mentally.
Yeah.
I'm really curious, Dr. Rhonda and Jessica, if you don't mind me asking, I'm really curious about any specific things or techniques, just new things you saw that really helped continue on the didactics, even when you couldn't maybe be in the hospital as much. What kinds of special things did you all do? And I've just gotten asked this, to groups around the country. What kinds of special things did you see that really kind of helped it move along, even when you're in such a tough time like COVID?
Zoom definitely helped a lot. I don't think any of us had even heard of Zoom before COVID started. So thank you, Zoom, for starting this. We also, obviously things like our clinical skills labs and things like that were, they were at group settings. Now, you can do individual. We do have a clinical skills lab that is 24 hours a day. I think that helped us out a lot and helped us to go in as individuals and kind of not lose our motor functions and motor skills during COVID era. So
Dr. Rhonda, did you do anything different on a personal level this time around for the Absite than you've done in previous years? I've also, been able to ask that to all kinds of our colleagues, and I've been really interested to hear some of the answers we've gotten. So on a personal level, anything different that you did?
I did. I started studying earlier this year, and I actually started listening to Behind the Knife, as well as the Absite Smackdown. I actually bought the videos and the books this year.
Okay.
So,
hey, that's what it's for. I didn't, we weren't for sure that you did or didn't, but it's nice to hear. Any other specifics? It sounds like you used a couple different resources besides resources and starting early and listening to the podcast, which we love, which is exactly why we do it. What else?
Really nothing. I did what most surgery residents know how to do very well, and that's hunker down and study. And
for sure,
as experience goes on and as we see more and as we do more didactics, you learn more and more. And to be honest with you, I credit a lot of it to prayer, and God's walked me through this far and has certainly helped me quite a lot. But personal level wise, I definitely enjoy and retain more when I hear things spoken out loud rather than just reading them from a book. And I feel that the video series and podcasts help me out a lot more than previous years where I would just read from, Pfizer or anything like that.
Oh, what a great attitude. And I'll tell you, it's great to hear. I didn't know for sure how much we'd talk about this ahead of time. Or how much we would talk about this during the podcast, but it's great to hear that you found some of the resources we put out useful. It's the whole reason that we do it. And I thank, Jessica and the publishers, because I really thought about what would I have wanted when I was a resident, what would have helped me and what would have made me be able to study doing different things, driving in the car, et cetera. And so the fact that you're using it for any of that stuff, I love to hear it. Jessica, I know I'm asking a bunch of questions. I know you had a lot more things you wanted to ask, but it's I'm just so glad to hear it.
The Absite Smackdown Podcast, bringing you the best for your Absite review.
Well, it's fantastic. I'm an auditory learner as well. And so I have the same experiences. I can read something over and over, but when I hear it, speak it out loud, it's said back to me, I retain the information so much better. And I enjoy that, the part of the series as well. So it's nice to have someone that feels the same way as I do. And you got that from it. So that's super awesome. Since we are on the subject of the book right now and you are going to be a contributor to version 3, can we get a little bit into that on your contribution, what you're doing, how you feel about it? I'm going to let you and Dr. David talk about that because obviously he's trauma surgeon too, and you are doing the trauma chapter. So let's get into it.
So Rhonda, what has been your experience so far with working with things? You know, how does it look to you? Where do you think the work for the 3rd edition should go with the part you're working on and the rest? I'm just interested to hear your input as somebody who's used it. We get so much feedback from everybody, so it's so good to hear. But where do you see it going for this upcoming one, especially your section?
I think that the book and the videos are done super well and very very high yield information in both, really. There are, the things that I can see that would make a huge difference are things like maybe putting some information into tables and charts. I feel like I learn more when things are, organized in tables and charts. And version 3, I think, including some of those. And I've already actually looked at the chapter and kind of, even while I was studying, kind of put things in my own tables and charts to help me learn it better. And pull things from different sections and actually incorporate them, because as I'm learning, let's say acute care surgery, there's also parts, or in trauma, there's also parts, like say from the pediatric section, that would have gone really well in the trauma section. While we don't want to repeat certain things, putting these things together and kind of building a correlation, I think would help people, even if they hadn't already correlated them in their minds, they can then correlate them on paper, and then maybe a light bulb will go off. And I think that would help out a lot more people.
Well, so interesting that you say that, because as we went through the 1st and 2nd editions with our colleagues, we kind of had to balance, hey, do we put this again in this chapter? Well, how long is this thing right now? Is this going to fit in your pocket? And those kinds of things. So it's like trade-off. The 1st edition was super small. We really wanted it to be in the pocket. The font was small. We got feedback, all right, guys, you probably need some bigger font. And then for the 2nd one, we did just what you said. We kind of, although we changed the font, things like that, we added some stuff from other chapters, we expanded it. And there's this balance between, you now have a huge book, congratulations, it's too big, or this fact should go here, this fact should go here. So it's great to have you on the team. I think that's valuable feedback. And it's also great because sometimes the feedback we get is very strange. I'll tell you this, and we haven't talked about it much. Jessica and I sometimes see the online feedback. She passes it to me, and the publishing team passes it to me. And we'll get some things like the videos don't track, the lectures don't track the book at all, and they're totally different. And I'm amazed by it, because I really feel like they tracked it pretty well. The guys made the slides and passed them along. They went right from the book. And I felt like the lectures tracked it pretty well. So it's always tough, because we want to listen to feedback. The idea is for every edition to be better, so it's more useful for all the guys and girls using it. And it's just really interesting, because sometimes we get stuff and we don't know what to do with it. Sometimes it's from other publishers. They're people who have never even watched the videos, because they can see who's watched them. So your feedback is super valuable, and I'm really excited to see what the next edition of the thing looks like. I think it's going to be great. Any thoughts on that? Or what are your thoughts on that, about the lectures tracking the videos, or anything like that, as someone else who's used it to review?
I think the videos track the book quite well. There are times where, it's a page ahead or a page before, but I can always honestly say, I know where you're going when you're talking. Like, I know what things you're putting together, and I know why you maybe skipped a page to talk about something and then came back to the topic that you were talking about.
Oh.
And it just flows. You can't you're not following a script more, you're following you're an educator, you're a teacher, you're following the train of thought that requires you to teach something completely and accurately. So no, I think that the video flows quite well with
Well, I
the
appreciate it. And under coming attractions, before we get to the next part, Jessica, I hope you don't mind me giving it away. The team, early on, they said, hey, David, would you please do these talks? But now, as it's, so gotten so much bigger, the goal is to not have David do all these talks, and it's going to be passed along to our colleagues in different ways, which I think is great. So anyhow, coming attraction, because you never know, sometimes you just don't connect to a person who's reading it and having and lecturing or talking or interacting with you. And so having more people do that, I think is going to be fantastic, because if Dr. A didn't work for you too well, Dr. B and Dr. C, they're coming. Those will be great. So anyhow, I again appreciate your feedback so much. Jessica, what else? What else do we need to cover?
The Absite Smackdown podcast is based on the best-selling review book, Absite Smackdown, the only Absite review with an entire video review course included. Visit absitesmackdown.com and pick it up today.
I mean, she's doing a great job. We didn't even have to pay her, and look at her giving you prompts. No, I am super excited about that. And for all your feedback, I'm glad it's positive. Some of the things you mentioned today, that I definitely want to talk about that with you when we're done with this, because some great ideas coming up. Why we do have you on, and it's awesome to talk about the book and everything, I would like to talk just a little bit more about the trauma and scenarios, and have you and Dr. David talk about that and get away from the book just a little bit, if that's okay with you, Dr. David.
Yeah, I remember you said we're going to try to incorporate some clinical scenarios, and Dr. Rhonda, our colleague, Dr. Barsoom, was nice enough to say, sure, we can do a brief scenario. I feel like I've talked a bunch already, but I do enjoy doing this. And so we'll get to it. And Dr. Rhonda, I mentioned to you briefly before we went on that we'll probably talk about a 35-year-old male who you are on call, I should start off with, for the emergency department for trauma responses, probably familiar to you as a PGY3. And sure enough, you get called when you're on call because a 35-year-old male is in a motor vehicle collision along the Las Vegas Strip. I don't know what would make this Las Vegas as opposed to any other place. Maybe he's covered in glitter. I don't know what you guys, it just seems like it's more, there's just so much more stuff in Las Vegas. I don't know what, but the point is he comes in as a trauma response, and sure enough, you're paged to the emergency department. How do you respond?
Okay, so I'm on call, so I'm going to go see the patient, do a focus history and physical, and start with my ABCs and start my resuscitation adequately.
Yeah, so sure enough, EMS brings the patient in, and you get an ample history. No allergies that you know of. They don't really know any meds. Past medical history, not really sure. Last meal, nobody knows. And what happens is he and another friend, someone else, were driving in this car where he was the passenger, and at a high speed, sure enough, motor vehicle collision head on. He was intubated at the scene without difficulty, and he is intubated and sedated and paralyzed, chemically paralyzed, as he gets wheeled in. Any other specific information that you want before you proceed?
So what kind of access do I have on him?
Yeah, so they do have 2 large bore IVs, and just to get us focused on the topics that we want to get to today, and I won't say them here in the video, but we'll put it in the links beneath so that I'm not tipping off Dr. Barsoom for where we're going or what we're covering. But I'll tell you, he's got 2 large bore IVs. His endotracheal tube does seem to be in place. He's hemodynamically stable with a heart rate of 110 sustained, but his systolic blood pressure is 120, and he's 120 over 80. He is being assisted with the ambu bag. You guys are going to transition him to the ventilator, but his endotracheal tube is confirmed in place. Any other specific information before you go on?
So now that we have our airway, breathing, circulation all under wraps, we can't get an adequate GCS, obviously, or an appropriate GCS. So I guess at this point, exposure. So what injuries do I find?
Yeah, so sure enough, you're not really able to understand his disability level too well. He's chemically paralyzed, but you are able to take everything off, roll him. He has decreased rectal tone, of course. You don't see any limb deformity in particular, and the rest of his exam, of course, is severely limited by his paralytic. But he does have equal chest rise and fall on breathing exam, like you said. And he doesn't, there again, no obvious extremity deformities. His pelvis is stable when you push on it. Really the exam overall doesn't show you much and is very limited. However, you think when you look at him that he may have a seatbelt sign. Just when you take his clothes off, you do see across his lower abdomen some bruising. Looks like it may be a seatbelt sign. How do you proceed?
So this sounds like it was a high level mechanism of injury. I'd like to take him, given that he's hemodynamically stable, I would like to take him for a CT of his chest, abdomen, pelvis. But given the seatbelt sign, I'd also like to obtain a CTA of his neck to evaluate for any blunt cerebrovascular injury.
So Dr. Rhonda, I probably wasn't as clear as I should have been. His seatbelt sign is on his lower abdomen, but let's say, and I don't usually change the scenario, and we're not exactly doing this oral board style. Let me be clear and say he doesn't have any seatbelt sign on his neck, and he does have one on his lower abdomen, which is where I was trying to go before. My question to you, and you mentioned screening him for a blunt cerebrovascular injury. Who do you like to screen for blunt cerebrovascular injuries? Who do you feel we should screen for blunt cerebrovascular injuries?
Yeah, so the literature is actually quite clear about screening that entails signs and symptoms as well as high risk factors, and a high energy transfer mechanism is actually one of the risk factors for a blunt cerebrovascular injury. Okay. Now we don't, we haven't seen anything on him yet to indicate that he's got a hemorrhage from his nose or his neck, and we can't really identify a neurological deficit. But given that he required even intubation in the field, I'm not sure if he's got a traumatic brain injury. Either way, if his GCS was less than 6 in the field, that would also put him at a high risk for a blunt cerebrovascular injury.
Yeah. I completely agree with what you said. And I'm curious in follow-up, one of the indications for blunt cerebrovascular injury is decreased GCS. But Dr. Rhonda, we get all these patients who come in intubated and sedated, and you can't really get a great neuro exam on them. They just had their paralytic or something along those lines. What are your thoughts on screening those patients? Do you feel like we should be screening them when we can't be sure of their GCS, or if it's low because it's medicated and low and they're intubated and we can't even get an exam? What are your thoughts?
I think the mechanism of injury is actually very important in circumstances like that. I mean, if a patient has a low GCS or it's not screenable because of, let's say a patient was found down, it's very different than a patient was in a head-on collision on, at high speeds. Okay. And it is highly suspicious that he would have a strong force that would cause an injury, and that's why I believe screening him. The other thing is, I know we're already obtaining imaging, and if I'm concerned about something, I feel that screening, especially in an institution where it is accessible, is definitely indicated at this point.
So Dr. Rhonda, sure enough, you take him over to the CAT scanner. CT of the head demonstrates no obvious injury. Of course, like you said, he may have anything from a noxic injury that shows up later. All these things can show up later, but there's no obvious intraparenchymal, subdural, epidural, and no skull fracture. His CT chest, abdomen, pelvis, he does have a pulmonary contusion on the left with a couple ribs injured, but no significant hemothorax. And again, abdomen, pelvis, no obvious injury, maybe a small adrenal lesion on the left. One of those kind of incidental adrenal lesions. But sure enough, on his CTA of the neck, he does seem to have a low-grade injury on that left side. So what are your thoughts on what makes an injury low-grade? And have you heard of this, sometimes called the Biffle grading system, or Denver grading system? Just depends. They get called both. What have you seen with that, and what do you feel makes an injury pretty low grade?
Yeah, so I'm more familiar with the Denver criteria, and that's a grading system that is a 1 through 5, 1 being a small or a very minor injury that results, I believe, in less than 25% luminal stenosis, with a level 2 being greater than 25, and I think a grade 3 is a pseudoaneurysm, with a grade 4 being a total occlusion, and a grade 5 being a transection of the vessel.
Well, sure enough, just like you said, this is one of those low-grade injuries. You described it very well. And now that we have it, what do we do with it? What do we do with patients like this?
So the literature states that a low-grade injury, grade 1 or 2, if it's a grade 2 or higher, some people will talk about surgically accessible or not. However, most of the time, these very low grade, grade 1 or 2, actually end up starting on antithrombotic management, such as heparin. And then a CTA is actually repeated in about 7 to 10 days.
Mm-hmm. And eventually, during this hospital course, you're able to pretty quickly wake the gentleman up and get him extubated. His pulmonary contusion's pretty minor. He doesn't have a clinically significant flail chest. You're able to get him extubated, and sure enough, just about 7 days later, when he happens to still be in the hospital, you are able to re-image him. It does look like it's still there, or at least the radiologist is not sure. So how do you proceed when you prep someone like this for discharge?
Yeah, so this specific kind of patient who on repeat imaging still does have an injury would actually be on an antithrombotic agent for about 6 months after discharge.
Mm-hmm.
Some people would consider stenting if it does become severe, or injury starts expanding into a pseudoaneurysm or such, or having any type of neurological function issues. But generally, it is an antithrombotic agent for about 6 months after discharge.
And so you're able to transition him from that heparin you gave him early on to now Coumadin, and he seems to be a Coumadin candidate, and then he's able to be discharged. First off, I really enjoyed talking with you about this. I think you absolutely nailed it with what's very standard practice. And when we get these patients, I wanted to share with you and the people out there who may listen, one of the hardest parts is they often don't just have, a blunt cerebrovascular injury. They may have a splenic injury. They may have a pulmonary contusion with a small hemothorax. And different centers do treat those differently. Some will anticoagulate even with, low-grade splenic injuries, and they watch the spleen. And these are different options. So blunt cerebrovascular injuries evolved so much since I first started in trauma. And I'm curious, Dr. Rhonda, have you seen any of the unfortunate or downsides of blunt cerebrovascular injury where it wasn't caught and the patient, God forbid, had a stroke or something? Have you seen any of that yet in your practice?
I have not, fortunately. We do screen quite readily for these kind of injuries. So that's one of the downsides of screening too much or too little, but when we do screen, we do find them. So
yeah, and like you said, you don't want to end up with everybody's sort of nightmare where the next day they start to have neurosymptoms, and that's the typical time course when it doesn't get seen. They have neurosymptoms and they have an infarct, and oh my gosh, it's just terrible. So it sounds like how you're being taught is really the much more standard way of doing it, and it's a good thing that you haven't had to see the downsides of maybe not catching one. So great talk with you about it. And I'll tell you once again, that blunt cerebrovascular injury management has changed so much. So Jessica, that's kind of how we do it nowadays with these injuries. And I appreciate you letting me talk through one of the scenarios with Dr. Barsoom like that.
That's great. I get to learn every day. Well, guys, thank you so much for being on today. Is there anything else that we want to add or talk about before we sign off?
I'll just reinforce how good it is to hear. The reason we spend the time and do all the work is for colleagues like Dr. Barsoom who have the ability to use all this stuff and use the podcast and hopefully use Daily Absite Fact, Jessica, and all the other things you guys do to get the message out there. It's really what I would have wanted when I was a resident. So I just can't tell you both how glad I am to hear it, that it's getting used like that.
I appreciate you guys a lot. And thank you so much for putting together something that is super helpful for all of my colleagues and me and all the generations to come of future surgeons. So thank you.
Hey, that's nice of you. It's great to have you on the team this year. And,
Jess,
thank you guys too. We're thanking each other all the time, but I can't say enough about it. So thanks, Jess, for being the publisher, a part of the publication team.
You guys make my job super easy. That's all I know. All right, guys, thank you so much for being on today, and thanks for listening. And we'll see you again next time. Don't forget, #Absite Smackdown.
Thanks for listening to the Absite Smackdown podcast. Visit us at absitesmackdown.com for more great Absite facts.